Hi guys, my name is Hope Gully. I'm a nurse practitioner student with Auburn University, and today I'll be talking to you about acute psychosis. Acute psychosis is a disorder where thoughts and emotions are significantly impaired. This can be its own diagnosis, or it can accompany other diagnoses such as schizophrenia, bipolar, depression, substance abuse, delirium, or dementia. Risk factors for acute psychosis includes history of substance abuse, especially cannabis or synthetics, a family history of psychosis, or a lower socioeconomic status. I wanted to include some provider tips when speaking to patients with acute psychosis. We first and foremost want to care about our safety. Always use a buddy system. Tell someone you're going into the room or bring someone in there with you. Always stand or sit near the exit when conducting the interview or the physical exam. And if HIPAA allows, then you can go to a more secluded area of the clinic with a friend. Always have the door open as well. When talking to a patient with acute psychosis, we always want to be non-judgmental. We always want to approach them with direct questions and answers. We never want to mislead or manipulate them. We also want to offer a lot of reassurance to them because especially in acute onset acute psychosis, that could be really scary for them. Also, when it comes to escalation, we want to be aware of our community's mental health resources. We want to be up to date on those as well as knowing your clinic safety precautions when it comes to more agitated patients. We also, I think it's very important for all providers to know and be able to practice well de-escalation techniques. This could be helpful in a patient with acute psychosis, but also if you have a really anxious patient or a really depressed patient. Key questions we should ask: do they have a history of drug abuse, a family history of drug abuse, or any psychological disorder, especially depression, anxiety, bipolar, or even dementia. All these are not only risk factors, but also can contribute and intertwine with acute psychosis. We want to evaluate their symptoms, especially if they're having positive symptoms such as delusions and hallucinations. We want to really evaluate those and ask, do they hear things? Do they see things? Do they feel things? Do we need to we need to be able to bring them back down to reality, and that again comes in with the direct questions and direct answers as well. We also need to evaluate if they're homicidal or suicidal. We need to do a very thorough investigation when it comes to that. We need to ask if they have a plan. If it's homicidal, do they want to kill anyone? Do they want to kill me? Do they want to kill a specific person? And when it comes to suicidal attempts, we want to know if they've had a previous attempt, if anyone in their family or a friend has committed suicide, because that's a high risk factor as well. For the physical exam, we want to evaluate their mental status. Typically in acute psychosis, they will have disorganized speech and behavior. They'll have kind of a blunt affect, and then positive symptoms, which are like the hallucinations and delusions, and negative symptoms, which is the blunt affect, and then like slow response and slow to answer. Constitutional, how do they look? Do they have any sort of indication of drug abuse? Do they have the teeth, hands, nails, anything like that? And what is their interaction with the provider? Do they talk to you? Are they manic, or are they very withdrawn and not talking to you? That can kind of help us determine what kind of level of acute psychosis we're at. And then musculoskeletal, especially if we start them on an antipsychotic, we want to have a baseline of their musculoskeletal system because of the extrapyramidal issues that can happen with antipsychotic medication. When treating acute psychosis, first and foremost, we want to do, as I mentioned, the musculoskeletal exam to determine a baseline, but we also want to determine their baseline metabolic function. So we want to have a fasting lipid panel, glucose, the whole CBC, CMP, LFTs, and then a waist circumference in their weight. This is important because antipsychotics, first generation, can cause extrapyramidal symptoms, which would be helpful with the musculoskeletal exam. But then atypical antipsychotics can also cause metabolic dysfunction and weight gain. So we want to know their baseline, and we want to be able to evaluate for those side effects so we can then alter their treatment plan. Our second line of treatment for acute psychosis would be clozapine. This was recommended by our Use Central app. It reduces the symptoms, and it can also prevent relapse, which is interesting, but it does have a fatal risk of agranulocytosis. So if we start them on this medication, we're going to want to monitor their CBCs pretty frequently. If a patient comes in and is acutely agitated, we can do the olanzapine. I would honestly say 10 milligrams IM, up to 30 milligrams in 24 hours, but you should not have them for 24 hours. You should definitely give them medication and get them onto inpatient. We also, anytime we start a patient on antipsychotics or any medication that is treating acute psychosis, we want to always accompany that with psychotherapy, and there's a few other therapies I've mentioned there as well. For patient education, we want to educate on the side effects and symptoms of the medication. So we want them to watch themselves for metabolic dysfunction and extrapyramidal side effects. If they notice a tremor, they need to call us. We also want to educate them on the support. We're going to talk about the medications when we prescribe them, but also they need to keep up with their medications. They need to keep their psychotherapy appointments. And do they have any sort of social support? Do they have people at home that they can talk to? Or is their treatment team basically going to be their only support? We need to know that so we can be more aware and we can follow it more frequently. Also, we need to educate these patients on when to contact us. If they have suicidal or homicidal ideations, they need to tell us, and they need to be comfortable telling us as well. That's our job as providers, is to make our patients comfortable to call us at any time. And then also we need to educate them on the extrapyramidal symptoms and that they need to call us when those do occur. And these are my references.